Okay. Excuse me. Okay. Just for the testing, let me check the snipe. This is what we have. We have a package insert. Reagent IFU for NTCCP. Let me check. Just give me a few minutes. So I have to check the IFU for. Okay. TCP. For reverse pyroglobulin. Now, ferritin. Insulin. Okay. So please tell me that you can see my screen. So you can see my screen. Okay. So this is the package insert of SNIPE, Meglumi, and TCCP. So if we go to the package insert, according to the kit insert, you can see that this is a quantitative determination of IgG antibodies to cyclic citrulinated peptide in the human serum and plasma. So it's a confirm that our assay is quantitative, right? And the other thing is important, which the unit. Okay. So let me check what are the possibility of units in us, because it's only one unit, U per ml. So here there is a unit of up to the 5,000 U per ml. Its limit of blank, limit of detection, limit of quantitation is also in U per ml. So only assay linearity is according to the CLSI EP6A guidelines. So my question is, if we have followed the CLSI guidelines for the linearity verification, and we are reporting this linearity from 0.78 to 500 U per ml. So as for my information, this is a quantitative unit, U per ml, right? But the other competitors like Roche and the Abbott, they have a U per ml unit, but the problem is they are using a cutoff value like less than 20, right? We are giving you a measuring range along with the reference range for these patients for the anti-CCP normal reference range. Okay, so while they are just given a cutoff, if the cutoff value of the patient value is less than the cutoff value, they need to consider as a negative. If the patient value is higher than this, they report it as a positive value for the rheumatoid arthritis with the respect to the anti-CCP value. But the unit is, this is quantitative unit in both, in terms of quantitative, in terms of semi-quantitative. If its answer is okay, if you need some more clarity, then please let me know. Okay, what is the standard used in this method to report a traceability? Only for the anti-CCP you required? Okay. So if we go to the package insert, let me check if they have defined as the traceability here or not. Okay, so this method is standardized against the internal reference substance because according to the Rheumatoid Arthritis Association or IFCC, there is no global WHO standard reference material guidelines for the anti-CCP assay standardization. So the SNIBE use its internal reference substance for the standardization and the traceability for the anti-CCP. Okay. Yes, the internal reference material is based on the U per ml unit. Okay, thank you. So this is a website from where you can extract all the package inserts. So this is the list number, and the all information, basic informations are available in each pack size, right? So you can take this information from that. And even the endogenous interference is also given in this package inserts. Okay. Let me check with the Abbott. Okay. Quick reference guide. Okay, no. Is quick URG. Can you see my screen? Okay. Anton? Okay, that's great. So if I make it more prominent here, like make it a little bit big, so you can see that the Abbott essay is listed here is showing a semi-quantitative determination of the IgG, right? You can see here, so the semi-quantitative determination of the IgG. Okay, let me talk about some more information from the internal reference. Sorry. Storage, stability, calibration, stability, sample volume, precision, LOB, LOD, NLOQ, clinical sensitivity, specificity, measuring interval, percentage, method comparison, and what no. So even additional, they do not have any confirmation that what the material they have used for the traceability and mhm. Okay, so let me check one more thing and then it will be confirmed. Mhm. If you have some more information, like if you want, let me share with you. I'm taking your time, but it's more informative. Just give me a few minutes so I can check if I have more information for you for anti-CCP traceability from the Abbott platform. So I'm not sure, but most probably they have also done some internal reference for the anti-CCP. Let me check with the package insert. Excuse me. If Abbott package inserts iSystem, that was metabolic. They have infectious. No, that will come in the congenital. No, they have some. Let me check here. CCP. No detection. Fertility. Male. So medium. Maybe they have not. Retrovirus. They have not. Renal. They have Enval only. For the metabolic, they maybe have anti-CCP. Exactly, they have a metabolic panel. So this is anti-CCP architect package insert. You can see here they are also claiming that's a semi-quantitative determination of the IgG, and in their package insert they have mentioned the instructions, specimen procedures, calibration, single types. They have a U per ml unit, quality control procedures. So linearity. high dose hook effect, interference, cross reactivity, method comparison with the exam, and then they in the LD they have a comparison with the architect. No, there is no mention about the traceability and standardization. No, there's nothing is mentioned in the package insert about the traceability. We need to check it what they have a traceability, but as far I know, for the NTCCP, they have their internal reference material for the standardization. Okay, so let's start with the remaining part. The remaining part is the EBV panel. So So in this presentation, we have a four part. First part is about the EBV virus. The second part contains the clinical application and utilization of this for these assays and the disease-related information. The third part contains what the solution which is provided by the SNI platform for the Epstein-Barr virus. And in the last, the epidemiological distribution and expected future CAGR for EBV virus and other markers. So let's start with the EBV virus. So what is EBV virus? EBV stands for Epstein-Barr virus. Basically, it belongs to the herpes viridae. It's a large family of DNA-containing viruses, which may cause the diseases in the animals and in the human as well. And you can see that this member of this family is also known as herpes virus. There are 8 kinds of human herpes virus has been found. That's an HSV1, HSV2, varicella zoster, Epstein-Barr virus, cytomegalovirus, roselovirus, HHV6 virus, which is HHV7. HHV8 is Kaposi sarcoma associated herpes virus, that's called KSHV virus. And if we talk about the herpes viridae classification, they can be classified into alpha, beta, and gamma herpes viridae. The alpha herpes viridae belongs to the simplest virus 1 and 2, and varicella zoster virus belongs to the alpha herpes viridae family. And if cytomegalovirus and roselovirus, that belongs to the beta herpes viridae family. And then the Epstein-Barr virus and retinovirus KSHV belongs to the gamma herpes viridae virus. So this is basically a classification of the genus, and then the further family contains the herpes virus, have different kinds of the viruses for the classification. So if we talk about the EBV virus, so basically Epstein-Barr virus is a virus which was discovered first time in 1964 by the electronic microscope of the suspension of the culture of African bucket lymphoma cells. So that's first found in the African bucket's lymphoma cells. Then the diameter is around 120 to 280 nanometers. The outer has an envelope proteins with also have an in lipid envelopes, tegumented, and then double-stranded DNA and the nucleocapsids inside that. So DNA composed of double-stranded molecule of about 172 K bases in the length, and then the DNA is surrounded by the protein nucleocapsid, and this protein tegumented lies between the capsid and the envelope. So this is a DNA double-stranded DNA-based virus that's called EBV virus. So the two main EBV genotypes are type 1A and type 2B, which differ from each other at the EVA nuclear antigen. That's the nuclear antigen basis. On the basis of that, they can be differentiated to a type 1A and 2B. So if we go to the global distribution of type 1 and type 2 distribution, which is excuse me, which is dominant in the Western Hemisphere and in the Western Hemisphere and the Southeast Asia, where the type 1 and type 2 are equally prevalent. In Africa countries, if we talk about nasopharyngeal carcinoma conditions, the type 1, type 2, and both types, the probability is more in China, Taiwan, Korea, and Japan, and even the US market, there's 100% type 1 is more as compared to the type 2, which is type 2 is more common in the Alaska states and in the other countries, like type 1 is more predominantly as compared to the type 2. So if we talk about the Central African, they have a 50% distribution or prevalence of type 1 and type 2 EBV virus. And then in Australia, their ratio is 27-30%. And then the regions like Western Europe, they have a 93% type 1 EBV virus as compared to the 5% of type 2B virus. So this is the overall global distribution of the EBV type 1 and type 2 viruses. And then if we talk about the transmission, so the transmission of this virus is either through the saliva or the droplets, or the blood transfusion is also a main risk factor for the spread of this disease, along with the organ transplantations. So in the healthy individual, the EBV virus is highly prevalent, and it's affect more than 90% of individual worldwide. So then in the developed countries with a high hygiene standard, they have a seroconversion peak in the children between the age of 2 to 4 years, and then also between the 14 to 18 years of age. And the ranges from 0 to 70% at the childhood and reaching more than 90% in the adulthood. So in countries with the poor hygiene standards, the EBV infection is usually acquired in childhood, and almost all the children in the developing countries are seropositive by the age of 6 years. So this is about the transmission and the seroprevalence of EBV virus. So if you talk about the lytic phase and the latent phase, you can see that the Epstein-Barr virus cycle in a healthy carrier that's begin with the infection, begin with the EBV infect the epithelial cells. So you can see here the infection begin when they infect the epithelial cells, and the naive B cells of the oral cavity EBV genome will transport to the nucleus of the beta cells, and where it is can replicate and result in the proliferation of the beta cells. And now they've infected the beta cells, and then the proliferation of the beta cells, which replicate and result latency occurs that the EBV down-regulated more of the protein encoded genes. So then the reactivation occurs and the viral shedding occurs in the latent phase and the lytic phase as well. So it's an all compartment reciting beta cells will be reactivated and cause the viral shedding. So this is the all lytic phase and the latent phase of the EBV virus. Once it's entered in the body and then it's spread in this procedure. So what are the diagnostics tools and the HBV, EBV infection rule out? The first diagnostics tools that can be used for the clinical findings, that the clinical clue. So on the basis of clinical clue like sore throat, fever, headache, and hepatomegaly, the non-specific laboratory tests like peripheral blood smear, heterophilic antibodies, or liver function tests also gives the this give the evidence of non-specific laboratory testing. If the EBV specific assay like EBV specific antibody test or viral detection and quantitation is performed, that gives you the confirmation for the infection of or the diagnosis of the EBV infection. So if we further go for a specific antigen test, that include Epstein-Barr nuclear antigen EBNA. The EBNA antigen is composed of 6 protein EBNA1, 3, 3A, 3B, 3C, and LP. So EBNA1 is important for the maintenance of the plasmid viral DNA in lately infected cells and inactivated of the viral DNA replication expressed in all EB infected cells. While the EBNA is essential for the immortalization of the lymphocytes by the EBV, while the EBNA 3A, 3B, and 3C is involved in beta cells transformation. So the early antigen is EA. The viral capsid antigen is VCA. The induced membrane antigen is MA. And the latent membrane protein is LMP. So these are the all specific antigen which are related to diagnose the EBV infection at different stage, like beta cells transformation or the EBV infected the lytic phase or a lutein phase. And then also they have an also induced membrane antigen, which is an evidence for the nuclear membrane reside mainly in the nuclear membrane and ER of the infected cells. So it can helps to homologous the HCV virus and then entry into the beta lymphocytes. So binding with the CD21, it's also an early indicator for this to diagnose the beta lymphocytes are involved in this infection. So if we talk about more EBV specific antibody testing, this level is different EBV infection stages. Like if we talk about antibodies level, different EBV infection stages, you can see there's antibodies level in the acute phase to the convalescent phase in the past infection. You can see that the number one is EA-IgM, VCA-IgM, and EBNA-IgM. These three markers will increase. Antibodies increase in an acute infection. Within a few days, then it's converted to do the VCA-IgA and EA-IgG and VC-IgG. So these are the three markers for the convalescence month infections rule out, and then the past infection after the years, it's EBNA-IG will help them to utilize that. So the antibodies levels in different EBV infection stages helps you to diagnose the acute, chronic, or the past exposure with the EBV virus. So these are the all markers here which are available, which include the anti-EBNA1 IgM, anti-VCA IgM, EAD IgM, anti-VCA IgA, anti-EAD IgG, anti-VCA IgG, and anti-EBNA IgG. So these are all the markers which are used in the assays so that you can be used for the diagnosis of EBV infection at different stage. So let's talk about the clinical application. If we talk about the clinical application, the disease related to the EBV infection, the number one is the infectious mononucleosis, the chronic active EBV infection, X-linked lymphoproliferation disease, nasopharyngeal carcinoma, Burkitt lymphoma, Hodgkin's disease, and lymphoproliferation disease are the the infections or the disease which are related to the EBV infection. So the infectious mononucleosis. Let's talk about some definitions. Then we will talk about the cause, manifestation, diagnosis, treatment, and the epidemiology. So if we talk about the definition, the IM infections, this is the mononucleosis, or a mono is an infection usually caused by the Epstein-Barr virus. This Epstein-Barr virus is spread through saliva, which is why it's sometimes called kissing disease. So the group stops healthy after bout, but the mononucleosis is positive to leave the nets. So in the clinical application, causes the Epstein-Barr virus above 80%. Cytomegalovirus, second leading cause for this. Human herpes virus 6, HIV virus, adenovirus, toxoplasma gonadie, hepatitis A, influenza virus A and B, rubella virus, and coxsackie aberranti viruses are the cause of this infection of Epstein-Barr virus. If we talk about the epidemiology, that's in college age student, the students who are going to the college levels, and common age is 15 to 25 years. And during this years, you can see that the clinical findings is the limited self-limit at 2 to 6 weeks. It's recommended. 4 to 8 weeks incubation period is existing for the HIV infection that can be shared and transmit virus for up to the 3 months. So that's an in incubation period, and then the spreading period is also defined here. The persistence virus shedding has been reported for up to the 18 months as well. The incidence and mortality is approximately 50% of the EBV infection population suffer from IM. So this is about the incidence mortality, and then the common cause, time, and the duration of the age group that occurs. So if we more talk about manifestation, the infection mononucleosis, you can see here the visual photophobia, central fatigue, malaise, loss of appetite, headache, that's throat soreness, reddening, lymph node swelling, and tonsils, and then the swelling of the lymph nodes maybe occurs during this infection of mononucleosis. The lymph nodes, there's swell. And then the tonsillitis is also a condition in which typical white blood cells characterize is also shows you that the EBV infections among the red blood cells as well. So these are the manifestations for the clinical finding of such a patient who have an infection with the EBV for the mononucleosis. So then we have a diagnosis. So on the basis of diagnosis is based on the history and exam, along with the laboratory evaluation and the imaging systems. So at the age of 10 to 30 old presenting with the symptoms, this is the first history and examination which goes a positive response towards this. And then you have to go for a laboratory evaluation for the lab test of EBV infection. If the EBV infection is positive, then the ultrasonograph can be used to monitor the spleen size, the abdominal. So that's the further investigation. For the help of this, you can go for the diagnosis of this infection of the EBV infection. So the diagnosis with the levels of antibodies which are specific for the EBV virus during the infection, mononucleosis, and convulsions. And then this you can see here during the IgM against the EBV VCA. There is a graph between the increasing antibodies titer versus the weak since infection, that you can see that the IgM against EBV VCA is increasing very swiftly. And then the second markers, which is the IgG against EBV VCA, is the second marker which prolonged for the lifetime. So just to rule out the infection, the acute infection for the EBV virus has an IgM VCA is positive, IgG VCA is sometime positive, sometime negative, and EBNA IgG is negative. That's interpretation should be as an acute infection or a past infection. The IgM VCA negative, IgG VCA is positive, and EBNA is positive. So in this case, it's considered as an past infection. So the infectious mononucleosis, according to this guidelines and this graph is acquired for the diagnostic tool from the Clinical Practical New England Journal of Medicines. So this is all information about that. And the treatment for such EBV virus is supportive care, antiviral medication with the corticosteroid in some severe disease cases, and the antibiotic to prevent from the secondary infections are the recommended treatment for such patients who have suffered from the EBV infections. So the clinical application for that the nasopharyngeal carcinoma. Let's talk about the definition, epidemiology, manifestations, type, stages, and lab tests in the treatment. What is nasopharyngeal carcinoma? If you see in the pictures, this is the nasal cavity. And then this nasal cavity, there is a first part is called nasopharynx. And then just below the nasopharyngeal area, this is called oropharynx. And then the oropharynx layer part is called laryngopharynx. So naso, oro, and laryngopharynx is a part of nasal cavity. If a carcinoma occurs at this stage, just close between the nasopharynx and oropharynx, that's called a nasopharyngeal carcinoma. Okay, so you can see here between this area, if carcinoma occurs like this, is called a nasopharyngeal carcinoma. So it's a rare type of cancer which affect the part of the throat connecting the back of the nose to the back of the mouth. So that's why they call the nasopharyngeal carcinoma NPC. So epidemiologically and risk factors, it's more common in men's as compared to the women's. So you can see that the races around it's the most common people in the part of China, Southeast Asia, and the North Africa. In United States, the Asian immigrant are at a high risk for as compared to the American-born Asian, and Alaska people are at also increased risk of nasopharyngeal cancer. The age can be occurs at any stage, but commonly diagnosed between the age of 30 to 50 years. They have a salt cure, the risk factors which are due to the salt cure product, food, Epstein-Barr's virus infection, due to the family history, and the utilization of alcohol and tobacco may lead to this disease. So if we talk about the epidemiological distribution of this disease, NPC is a more common in Asia Pacific Island. You can see here the China, India, and some part of Middle East, and then some part of other countries like European countries, they have a more prevalence, which have 6 times more often white peoples as compared to the Hispanic people. And Alaska natives are more likely to be developed NPCs. And the prevalence, according to this WHO, International Agency for the Research on Cancer data for the 2018 feedback, is the darker green color has a more prevalence. In the Latin America, you can see here that the prevalence is also between 1.7 to 2.7 as compared to the greater than 2.7 prevalence in the African markets, and then the Middle East countries, and especially the Asia Pacific region. So if we go for a clinical finding or manifestation, a lump in the neck, that could be lead to the this disease. The hearing loss, usually in the 1 years, a blocked or stuffy nose, a nosebleed, or tinnitus. So these are the manifestation or clinical finding for this disease, and there are three main type of NPC: the type 1, type 2, and type 3. They look different under the microscope, but all start with the epithelial cell, that line that's the interface for the nasopharyngeals. The keratinization of the squamous cells carcinoma, and this is type 2 is a non-keratinizing squamous cells carcinoma, and the type 3 is a basaloid squamous cells carcinoma. And they have a different risk factor through which they can say that, or due to the smoking and drinking habits, that may lead to the type 1. And then some, this is an type 2 is a more squamous cells carcinoma with the non-keratinizings. It is mostly linked with the EBV, having 60% of the NPC in the adult is due to this. And then this is aggressive carcinoma, which tends to spread more quickly to the surrounding tissue and the lymph nodes as well, as compared to the keratinizing squamous cells carcinoma and the basaloid squamous cells carcinoma. So this basaloid type 3 squamous cells carcinoma is a rare and it is aggressive type of NPC. And this is the basaloid squamous cells carcinoma of other area of the head and the neck. So it can spread into there and then leads to some further complication. So if we talk about the NCCN guidelines version 1.20 staging head and neck cancers, so they have some primary tumors and regional lymph nodes guidelines. And according to this guidelines, the conclusion is that to rule out the anatomical stage of the prognosis groups for a different stage, like non-distinct to the distinct metastatic stage, according to the histological ground, is the stage 1, 2, stage 3, and stage 4, and a stage 4B types. So if we talk about the lab test, imaging, biopsy, and serology to rule out that disease, we have a imaging system. We have an MRI, CT scan, and the tomography, PET, neck ultrasound, and the chest X-ray may help to diagnose this disease, along with the fine needle aspiration, FANC, FANAP, and the core biopsy and open neck biopsy and the gold are the gold standards testing for the lab testing. If we talk about the serological testing, yes, SNIPE has a solution for the EBV infection testing with the routine blood samples for with serum and plasma, both are applicable for the serological testing from the automatic platform of the SNIPE instruments. So if you go for the World Journal for Virology, to rule out the nasopharyngeal carcinoma, there is an serological profile for the Epstein-Barr virus, reactivation, and some Epstein-Barr virus associated diseases. So these are the all 5 diseases which are related to the EBV virus infection, like chronic active infection, Burkitt lymphoma, nasopharyngeal carcinoma, Hodgkin's lymphoma, and reactivation. So if we talk about the nasopharyngeal carcinoma, you can see here the VCA IgM will be negative, VCA IgG will be twice positive, VCA IgA will be positive, EAD IgG will be positive twice, and EAR IgG may be positive or negative, while EAIGA is positive and EBNA1 IgG is positive. So this is a normal EBV virus testing profile results for the diagnosis of nasopharyngeal carcinoma. If we talk about the lab testing, the sensitivity and specificity of EBV, IgA, VCA titer is around 89% sensitivity in greater than 5 values and 83% in greater than 10 and greater than 20 titers of 82%. So the specificity as compared to the sensitivity for the EBV, IgA titer, VCA titer with the diagnosing of NPV is around 97 or 98 and 99%, with the concentration of greater than 5, greater than 10, and greater than 20 respectively. So the overall conclusion for the antibody and the sensitivity and specificity and application is the VCA-IgA is a sensitivity is higher, the specificity is ideal, and that can be used for the screening purpose, while the EA-IgA is journal sensitivity and then a higher specificity, but it can be used for the verification of EA-IgA infection. So let's talk about the lab test. According to the complementary serum test of antibodies to the Epstein-Barr virus nuclear antigen 1, an early antigen, there is an impossible alternate way of primary screening of the nasopharyngeal carcinoma. So you can see here the EBV-VCIGE and then the sensitivity versus the specificity. The overall conclusion is the finding indicates that the EBV, EA and EBNA1 is the most feasible tool for the NPC mass screening because it's not only has the highest AUC or ROC curve, but it's also easily, you can see here. Oh. So you can see here, they have highest AUC and ROC curve. And then on the basis of that, they only easily perform the rapid, accessible, and highly cost-effective analytes. So this is overall conclusion for the clinical lab testing for the EBV infection. So let's have to go to the next slides. It's in the next slide, we have a treatment. So the radiotherapy by physician is recommended along with the chemotherapy, or a surgery may lead for the treatment of further disease. So let's talk about what the solution SNIDE is providing from the Maglumi platform. So we have a EBV virus. Let's have a comparison. So you can see here the EBV panels. The EBV panels include EBV, EA, VCA, and NA. So these are the three specific markers to rule out the different stages of EBV infection. So you can see here. Okay. Right. So for this, EBVEA has all these three markers, IgG, IgA, and VCA has a three marker, IgA, IgG, IgM, and IgA. The EBVNA is IgG and IgA. So as of today, among the other competitors like Roche, Siemens, Advia, Imelite, Architect, Alinity, and Biomurex, even with the manual procedure of Biomurex Vidas, and then they have a Beckman Unicells and Abbott-Alinity, we have a very comprehensive solution for the EBV panel, right? So if we go to the further slides, you can see here. In the EBV panels, we are very much comprehensive, but still the overall parameters are like EAIGM is missing still, but the diazorin and the uramine, they have this. And then the EBVNAIGM is also missing from this Meglumi platforms. But these are all available from the uramines, have also missing these NA, EBV, NAIG, and IgM. And a few are also missing from the DRG and diazorin, while the IBL has a more comprehensive panels. And so in the future, we may launch about the EBV, IgM, and the EBV, IgM. So the IgM markers are missing from the SNIDE Meglumi platform, but it's available from the IBL platforms. So that can be available in future soon, because as of today, we have 235 analytes. So if we talk about one by one EBV, EAIGA, so the internal specification, we have two generation, the first generation and two generation, both are qualitative analysis, and they have a serum and plasma recommended in the second generation. The sample volume and onboard stability is enhanced, and calibration intervals, and the pack size of 150 test is available. So the 1 month utilization is recommended on the basis of workload. The customer can be decided what number of samples can be, what number of tests be required to complete, utilize the reagent within a 1 month. So if we talk about the EBV EAIGG, so this EBV EAIGG specification, as we have two generations, the first generation assays and the second generation assays. These are both indirect chemiluminescence and the quantitative assay. In the second generation, we have improvement of serum and plasma levels, and the onboard calibration interval or onboard stability is enhanced with then recommended utilization of 50 tests or 100 tests should be within 1 month. We have a flexible pack size according to the requirement of the lab. So these are those parameters which are required some special attentions. So you can be use a lower pack size if your volume is low, because the testing for this is a low in different cases. So if we talk about EBV, VCA, IgA, this is also, we have a first generation and second generation. So you can see that the first generation and second generation both are qualitative analysis, and they have a serum and plasma both recommended, and 28 days a calibration interval with the onboard stability recommendation of 1 month. And we have a package size of 50 tests and 100 tests available. If we talk about EBV, VCA, IgG, we have a competition in this parameters with Roche, and Siemens. If we talk about the next generation assay, that we have a second generation comparison with the Roche and the Siemens, you can see that we have an indirect CLIA chem technique, but they have a sandwich technique and then chemiluminescence immunoassay technique. We have a qualitative, all of them have a qualitative analysis. Both serum and plasma types is available for that testing, and the 10 microliter sample, which is almost equal to the SNIPE Siemens assay as compared to the Roche's, and high sample volume is required. We have a very enhanced calibration interval of 28 days, which is an edge of onboard stability and the reliability of assay in case of low volume EBV, VCA, IgG testing. So the onboard stability is 4 weeks, and then the Roche is in 28 days, and the Siemens most probably has need to be checked, because as of today, we do not have any data for the onboard stability. If we talk about the packages, we have a 50 test and 100 test pack size, while the Siemens and Roche, they have 100 test and 200 test pack size, which is not lower than 100 and 200 test pack size. So this is the information about the comparison of EBV with the VCA IgG. So if we go for a more comparison for each analyte, like IgM, EBV, VCA, IgM, we have a competition with the Siemens. So the second generation is definitely the improved version, because their serum and plasma sample type is improved, onboard calibration stability is improved. On the basis of this comparison with the second generation with the Siemens, is that we both are qualitative, and then we have an edge of onboard calibration interval stability, and then the onboard stability is not available for the Siemens, and they have a pack size of 200 packs test kit. So for the customers who want to use this Meglumi EBV, VCIGM, we have a flexibility of 50 tests and the 100 tests, while the other competitors, they have a bigger pack size of 200 test pack size, and if they want to use, they can you have to buy a 200 test rather than the 100 test or 50 tests as we convenient are in our package pack size. So if we talk about EBV, NA, IgG, that's we have an edge of calibration interval. We are equally good in sample types and sample volume, and we have an onboard stability is a little bit better than the Roche, and we have a flexibility in the pack size of 50 tests and 100 tests. If we talk about EBV, NA, IgA, we have method and principles. And according to that, we are using an indirect chemiluminescence, while the yellow has an availability of this microbeads immunoassay. For this, we have a qualitative assay testing. We have a sample type of serum and plasma. We have a sample volume of 10 microliter. Onboard stability is equally good, along with the onboard stability of 4 weeks and the calibration interval of 28 days. We have a flexibility of pack size of 50 tests and 100 tests, while the yellow has an only 100 test pack size availability. What are the advantages compared with the other market players with the Meglumi EBV? We have a most competitive menu among all the other autoimmune assays competitors in the IVD market. We have a very comprehensive menu. We have a very less incubation time. Even we do not have an electrochemiluminescence technique, as you know that the Roche is claiming that they have a shortest turnaround time due to this electrochemiluminescence technique, the small sample volume, and the broad measuring range. And then there is no carryover due to the disposable tips. But these claims are not practically proven. In just few assays, they have 18 minutes and 9 minutes, while otherwise they have usually a pre-treatment assay, which incubation time is more. If the assay time is if the assay time is low, so why the instrument throughput is less than the SNIDE analyzers? So it doesn't matters in the IVD market. Majority competitors like Abbott, Siemens, Vitros, they are using chemiluminescence technique rather than the electrochemiluminescence technique. And the biggest drawback for the electrochemiluminescence technique with the Roche is all the mixture goes to the measuring cells, and then the cleaning of unwanted materials occurs at the measuring cells with the pro-cell material, which is called a tripropylamine. This tripropylamine has a two activity. Once it's clean the flow cells of the unwanted material and then send it to the drain area, only the immune complex, which contains the streptavidin-coated microparticles, and then it's bind with the magnet at the measuring cells, and then the reaction start with the conversion of TPA to a radical, and then this radical react with the ruthenium, and then this ruthenium emits the light, and detectors photomultiplier send it to the photomultiplier, and then photomultiplier into the detector to detect the signals of unknown samples. So in the whole process of Roche, the probability of contamination is occurs. That's why their infectious results are not up to the mark or the expectation of the customers, and they have a lot of variation. And the maintenance is required if they want to run, especially the HBsAg test on E411. So we are mostly less incubation time, even with the electrochemiluminescence, so-called less incubation time. We have a short measuring time, low sample volume. If we compare with the CLIA technique, we have a short measuring time, sample volume is low. If we compare with the ELISA, we have a fully automated, we are providing a precise result. While in the ELISA technique, it's a very factors influential procedures, because different people have different handling, so it may lead to the variation or imprecision in the results. But automation has only a one steps to load the correct samples along with the guidelines for the storage, and if they are using the fresh samples. So the fully automated gives you the more reliable and precise and accurate results as compared to the ELISA techniques. So if we talk about the Meglumi EBV, there is no EBV international standard material yet. So the different IBD manufacturers have a different traceability chain. Therefore, the results from the assays of other manufacturers cannot be interchangeable. So this is the most important thing about that. If you talk about the marketing potential market, that's an Epstein-Barr virus and the human papillomavirus are associated with the 38% of all virus-associated cancers. So the prostate cancers in Sweden, 8.8% co-infection, and the 37% in USA has a co-infection with the subtype of HBV and the EBV. So they have been detected, the EBV Epstein-Barr virus and a human papillomavirus, the nasopharyngeal carcinoma, encoded RNA, and the others fragmented proteins, and then the antigens are detected during this co-infection of EBV in several malignancies. So if we talk about the target market, the EBV serological testing are especially suitable for the screening of cancers, like cancer centers, ENT department, and the hematology departments can use this EBV serological testing for that. So this is all about the EBV. If you have any question, you can ask, or you can take any comments for that. So any question? Anna, Artem, Abramochkin, Serdiok, Irina E, Irina M, Evon, Kirill, Melia, Megomedov, Sergey, and Aha. So do you have any question? So do you have any question? Okay, no. So there are two reasons. If you are not asking a question, so maybe the presentation is not so good. Or if you have asked few questions, yeah, yes, I remember. So I have sent you in the beginning. Those who comes late, please copy the link. So please confirm me that all of you have copied the feedback link for today and the yesterday training feedback. Everyone has copied this link. If you miss, I can give you again. So now you can please send this link. I send again. Yes. So please copy this link and save, because once we leave that meeting, you will not be able to copy that link. And the second thing that I have shared with you, I hope you will also read this. Please read this. This is a good information. Like I asked my training colleague in Chinese colleague in China, they told me that they have a comparison with the Mindray. So please contact your Chinese colleague in Russia. So they will share with you soon. In case of delay, please contact me so I will follow that, right? So if you want any information in the future, or if you want anything from us, so we are more than welcome. Okay, so we today, without just one break of around 7 or 8 minutes, you have done a great job without having a break. We have complete 20 minutes prior. If you have any question, you can ask. We have still 20 minutes. Otherwise, we will finish it before 20 minutes. It's up to you. If you have any question, even other than this, you can share with me the challenge you are facing in Russia against Roche, against Abbott, or against any instruments or any analytes if you are facing a challenge. Okay. If do not have any questions, we can close this training session now. Okay, just give me a one picture. I have to take one picture and then we will leave, right? Okay, thank you very much. Have a good time. See you. Bye bye. Okay, bye bye.